Hi, Paul.
Hi, Brian. Sorry about that, my friend. So I know that you're busy.
That's all right.
We're just going to get the guys back in. We asked them all to come back for 11. They're coming back in now, my friend.
Okay.
So, are you busy?
Yeah, I'm down in Gloucester today. I'm just heading off to run a TCT in about 20 minutes.
Ah, that's right. We'll only keep you for about 15 if that's okay. And then we've got Saeed
Yes.
Din, who's been doing a lot of work on polyp. He's going to come and talk as well. And then after that, we've got Lorraine. We'll see what she's got to say for herself.
All right, good.
Hi, Brian.
Brian, it's Saad
Morning,
says
you
hello.
right? Well, afternoon over there.
How are you?
I'm good, sir, thanks. You well?
Yeah, good. Thanks for being with us and at a very odd time. We'll look forward to
Yeah, no, that's fine. It's 7 in the morning here, so big day for Scotland today.
Yeah, it is. It is a big day for Scotland as well as I think you.
What are you voting, Brian?
Oh, that's it.
I don't get a vote because I live in England, but I would be voting no.
Okay. Now, my friend, what we got, I know you're very pressed for time. I'm just going to introduce you. This is Brian McCaig. Brian McCaig is the national lead for training, so the Joint Advisory Group for endoscopy. And I'm going to ask Brian just to give you a little bit of background to what that's about and the importance of it and how it's affected the UK. And then Brian's very pressed for time, so he's got to go and do some teaching on another course. So please feel free to ask questions. If he has to go, then I'll take over. So Brian, over to you, my friend, if that's okay. What's happened there? Lost him again. Yeah, it keeps freezing, my friend. Will this be the... It won't be the connection this side, will it? It will be...
It's very fast from here.
So what JAG is, the Joint Advisory Group, some years ago, it was decided that the standard of endoscopy, when we look around in the UK, was very varied. And I'll just wait. Are we okay, Brian?
Yeah, I can hear you.
Excellent. What's
You
that
got
say?
me back again, yeah?
Yeah. So, Brian, what I've just done is just let them know that a little bit about yourself, and I was hoping that you'd be able to tell us a little bit about your role and about how training has changed endoscopy practice, in particular colonoscopy in the UK.
Okay, yeah, no problems, Paul. It all really sort of stemmed from a decision by the UK government probably about 20 years ago to roll out a bowel cancer screening programme. And it was fairly clear from audits at that time in the UK that colonoscopy practice was inadequate to serve that system with intubation rates mid-50s. So at that time, there was about 4 or 5 enthusiasts in the UK who were running basic skills colonoscopy courses, a bit like what you've been experiencing over the last few days with Paul. And the government approached those centres and injected a lot of capital, a lot of money to set up 3 national and 10 regional centres. And then over a period of 3 years, they paid for as many people as possible to attend these courses. And what that allowed us to do in the UK was to very much standardise the courses that we were delivering. So the same course would be delivered where I work in Wolverhampton as it would do in London or wherever else. And that allowed us to develop quite a clear, safe way of doing colonoscopy that we could then teach and export and develop. And part of the critical things about that was developing the right faculty to come on the courses, because the faculty would not only teach just on the courses, but also when they went back to their base units, the faculty would be teaching their own students there as well. So we started very quickly developing a network of how to train in colonoscopy. And that started now, it was probably back in 2002, so we're about 12 years into that process. And one of the sort of great things that we've seen from that is that there are the cohort.
Lost it.
And they put, things in.
He was worried about the connection when he went down. He was saying that to me. That not from our point of view, but from me. He's actually in a hotel down in Cheltenham. Yeah. I'm sorry about that, Brian. I've just gone for a normal audio to see if that helps.
Okay.
So where we were, what you were saying is about 12 years ago, we were looking at in 2002. We heard that and
Okay.
a couple of points more, sorry.
Okay, so around 2002, that's when the first courses were, well, the first set, the training centres were set up. So we've had about 12 years of experience, and what we can now see is that the cohort of colonoscopists who are coming through as trainees who have trained within the last 10 years, and a good cohort of relatively young colonoscopists are all endoscoping and training people in the same way. And what we've seen is when we've repeated audits of colonoscopy practice in the UK, that intubation rates have gone up to over 93% across the board, which obviously is a much healthier figure. What it's, I think, really importantly also allowed us to do is within endoscopy, because it's done by gastroenterologists, surgeons, nurses, and a whole range of people, this process has allowed those cohorts to become unified under what we call the JAG, which is a joint advisory group for GI endoscopy. And they've been able to utilise the training process to develop standards for what we feel would be minimal acceptable standards to allow people to practice independently. So what it allows us is quite a robust system of training and assessing individuals before they can then become an independent practitioner and then subsequently train other people as time goes on. So that whole initial sort of impetus from the government in the early 2000s, we see has paid off a huge amount of dividends in terms of developing not only sort of good colonoscopists, but also faculty and courses and an accreditation system that I think is now very much embedded in how UK endoscopy is trained and accredited. And that's built not just from colonoscopy now, but also to all other modalities of endoscopy, which is great because everything is becoming much more standardised. And I think also as trainees and new endoscopists come on board, they very much accept that this is how you will be trained in endoscopy in the UK. These are the standards that you need to meet, and that everybody signs up to them. And it's quite strongly imposed that, if people are...
This is the problem with the connection sometimes.
I think what we'll do, because his connection's poor and it's causing a problem, I'll just have a quick chat with him just to hit a few points, and then I'll continue with what he normally talks about. Because
Yeah, I think that would be
Brian,
No,
thank
Paul,
you. I'm sorry, my
keep
friend.
getting cut.
What I
Not
was
sure
going
if
to
it's
say
your
is,
end or-
it's not very good today for some reason. What I was going to say is, can I just ask you a quick point on what are the main key performance indicators that we want to hammer home to trainees, what they should be keeping an eye on? And then I thank you very much. And then because of the connection, we'd have to let you go because it keeps disappearing for some reason.
Okay, yeah. I mean, I'm not sure if you've been able to demonstrate or show the JETS portfolio, but on that, the things which we are assessing our trainees on initially is they have to meet a certain cecal intubation rate and have done a certain number of procedures. We don't particularly, to get provisional certification, which is up to 200 procedures, 90% cecal intubation rate, we don't look at a lot of the other KPIs that we might look at ourselves as independent practitioners, like adenoma detection rate, complications, miscancer rates, because these things are all really, if we were measuring them as a trainee, what you're essentially measuring is the trainer's KPIs. So we get people up to a level where we feel they can competently do the procedure with a 90% cecal intubation rate. And then after they get provisional certification, they need to do another 100 procedures where we do measure their sedation rates, their comfort scores, their adenoma detection rate, any complications. And if all of those are meeting the required standards, then they get full certification after they've done 300 colonoscopies, and then they can then practice independently. And obviously each unit in the UK has regular ongoing monitoring of all their individuals' practice. So if that slips down, further training, if needs be, can be put in place.
Thanks very much, Brian. Can I just for the purposes of SARD and a couple of people, experienced colonoscopists in the audience, can I just ask you just to briefly touch on the 3-year study that's going on about looking at colonoscopies that were done in the last 3 years and of experienced colonoscopists for cancer, miscancers. So just something.
Yeah. So the whole raison d'etre really for doing colonoscopy is to find cancer and to find pre-malignant polyps. So one of the key performance indicators that we're now beginning to information and data on is the post-colonoscopy colorectal cancer rate. We've looked in the bowel cancer screening program at that recently, and the sort of, if you like, the post-investigation colorectal cancer rate is around about 1.5 to 1.6% for colonoscopy, which, when we compare that to the symptomatic service, the missed cancer rate is around about 8%. So we can see that even in a general, what we would consider fairly high quality colonoscopy program in service, there's a very high missed colorectal cancer rate, either from poorly resected or incompletely resected polyps, or from missed lesions because of poor visualization. And then I think you need to accept that even in the very best hands, and if you look to the bowel cancer screening program, that's probably the most controlled group of people who we have. There's still going to be a miss rate because of a variety of reasons, whether or not that's prep, incomplete procedures, just missing, pre-malignant polyps. But that rate of around 1%, 1 to 2% is probably the lowest that's ever been identified or quoted in any papers. To look at this in more detail, the UK is setting up a national endoscopy database so that all the information which comes from any endoscopy which is done and put on a reporting system will go into a national database. And I think what we'll see once that develops is that we'll get much clearer idea, and individuals will be fed back specifically what their own missed colorectal cancer rate is. And I think that will be a critical thing in helping to identify those who are performing well and those who aren't performing well.
Brian, I think that's really important, because that's something that talks about variance of practice, and in an area that we can see, which is Pakistan, where there's a lot of variability, that is something that I think would be many, many years off. But I'm just going to throw open quickly to Saad. Have you?
Just one, Brian, we had this discussion before. You've gone a long way in improving and standardizing and uniforming the practice of colonoscopy. It would be really nice if somehow or the other, through our society or through our systems here, we could have some kind of certification for non-UK people, because I think you've now almost achieved everything that you wanted to do, and now it's just the systems are in place, so you just need to let the systems work. But maybe something that you need to think about, and we would be very happy to be the guinea pigs to start with, and see if we can bring in the significant things or things that have made a significant difference in your practice overall to our part of the world. I don't know how that would be possible, but one of the things that comes to my mind is through our Society of Gastroenterology, maybe, or through centers that want to participate voluntarily. Just a food for thought. I'm not sure. Thanks.
Yeah, it's interesting actually. We recently, about 2 or 3 months ago, we were approached by the World Gastroenterology Organization to run an international train the trainers course for some of the WGO centres. And as one of the outcomes from that, it was very much about how we can potentially share some of the platforms.
I'm not going to do it.
Did you all understand what Brian was saying? There are a few things that we'll just reinforce.
It's part of the Scottish accent.
But I think his accent is very good. It's a very, very posh Scottish accent.
What I'm going to do is say thank you to Brian when if he answers, because
Keeping him for.
I'm delaying him.
Just say thank you and.
But he's very, very a supportive man. You won't believe how supportive this chap is. It's not about himself. It's not about anything at all. It's about trying to promote the best in an area that he works in. So, and
Hello.
sorry, Brian. I know what you said about the meeting. I know that you're pressed for time. If you feel that you got time to actually finish the point, not a problem. But
Yeah, sure. Yeah, no. What was saying was that one of the outcomes from that meeting was sort of a commitment to identify what materials, both educational and IT, in terms of platforms from the JAG, that could be shared with some of the WGO and other international centres to try and help support, frameworks for developing training within those countries that haven't got things set up. So it's quite early at the moment in terms of that process, but I'm sort of fairly heavily involved in trying to identify and help sort of develop the other WGO centres, and that may be a template for what we could potentially help out with you.
That's great.
shit.
In the UK, the first colonoscopy audit took place, which was very embarrassing, and that showed the deficiencies. But the good thing about systems that are being monitored is that they were monitoring, they did that audit, they realized they needed to improve, and then came the whole change. And today it's completely transformed. And I think their system today is probably one of the best in the world. And very, very stringent. You heard few points there, 200
Just try 'em
colonoscopies,
once more, shall I?
90% cecal intubation.
Just say thanks.
Okay. That's when you are allowed to do independent colonoscopy. Okay, so 90% cecal intubation. Be honest with yourselves. You're working in different departments. I've not seen publications coming out about cecal intubation. So we need to be careful.
Brian, thanks very much for everything you've done, my friend. I think you've
No
got
problem.
everybody
Sorry,
excited.
It's been a bit of a dodgy connection
It's
this
a
morning.
dodgy one this time. Brian, absolutely brilliant, and I know that we're on a course together soon. Hopefully the course goes well that you're on, and I'll see you very soon, my friend.
Okay, good to see you all, and I hope things go well over there in Pakistan.
They will, my friend.
Thank you.
You look after yourself, Brian.
Yes.
Good luck with today,
Okay,
and good luck with your vote.
take care. Thanks, Paul.
Bye.
Bye-bye.
So you heard the 200 scopes, you heard the cecal intubation. That is what qualifies you, or the basic requirement is. And then he mentioned about another 100 cases where you're evaluated. There will be some more details about it. If we get time, Paul is going to show us how they monitor everybody who's doing endoscopy in their unit, and then in their region, and then now they're telling us that the entire UK thing, the data we are talking about, the numbers we are talking about are phenomenal. So when we get those figures out, it would be really, fantastic for everybody. So the point is that they realized there was a problem. They started like we have started, okay, and then they kind of got the government involved, they got their societies involved, and now it has become very organized. And what has it done? What it's achieved is that all of us sitting here, would have almost similar basic standards. Some of us are going to be very good, 98, 99, 100%, whatever, but majority, average is going to be good. And that's what they have achieved. And that's what we should strive to do as well. And as I said, we'll touch that. Paul has a presentation which will give you a little bit more insight. So when you grow in your department, I think you need to sit down, think. You've got 5 people operating. Are they good enough? Should they be allowed? That's what you need to start thinking when you reach that stage. Today, you need to learn and get your 200, get your cecal intubation 90%. That's your aim. Okay.
I think this what Sat touched on. I was, sort of lived through that change, and one of the things we should all accept is that we should be prepared for a change. We should be prepared to be audited. When it came out, there were over a dozen people who were endoscoping in our department, including surgeons, other physicians, other gastroenterologists. And when we audited ran our initial audit, there were 2 of us who satisfied the criteria. The rest were scoring well below the mark. And we supported the rest of our colleagues by giving them training sessions. My colleague and I used to stand with them and coach them. There were some of them who we thought were not totally hopeless, and they were not performing enough, so we politely requested them not to continue with the practice. The other ones, we supported them, and over a few months' time, they managed to come up to the standards. So I think the main thing is we have to accept where our deficiencies are and try to improve on them, because there's been a major culture change in the UK. In the past, when we were trained as registrars, the training was fairly unstructured. My boss would tell me to get on with the procedure and give him a shout if there was any, I was in trouble. And I would hardly ever give him a shout for help, because it's a bit of embarrassing to bother your boss, and culture was such. But then, since all this has changed, we have been carrying out one of the most structured training program. With the DOPS have come, the JAGs have come. So the situation we are in Pakistan now, it doesn't mean that we have to stay in this forever. We should be prepared for change, like near Pakistan. And that is near.
We will have a discussion about this over a cup of tea.
Right. Anyway, I am totally apolitical, so this is nothing. It's just a slogan. So the important thing is that please be prepared to improve your practices. Be prepared to audit yourself. Initially, it is human nature. Even in UK, most of our colleagues when they had not reached the cecum, they would give, the commonest excuse given was poor bowel prep. And it is not, with the bowel prep we are using, the poor bowel prep is not so frequent. So they made it a requirement that when you reach the cecum, you should take a photograph of the cecal pole and ileocecal valve. So that became mandatory. In every endoscopy report, there should be a photograph to justify that. If you haven't got that, you've not reached the cecum.
You wrote something.
If I don't have photographs or facilities to take photographs,
Was he right?
Yeah.
He wrote something and then said, no, I don't want to write that. He's probably suddenly realised he'd write something like he and I were told, and then he thought, oh no,
that I
better
have
not.
reached the terminal ileum, and somebody said that there was something in the ileocecal region, and I'm saying there is nothing. CT scan is saying something, I'm saying there is nothing. You tell me, I've seen the terminal, I've been up to the cecum. How do I know you did? So I would go into terminal ileum, take biopsies, say, I took biopsies from the terminal ileum, so I've been all the way, there is nothing.
I just quote you an example.
But what I'm saying is that's only occasionally. But now with the pictures, now with the videos, if nothing else, take your camera out, phone, take a picture, and that's it.
I think I'll quote you an example. One of my colleagues.
Surgical friend coming down, or?
Manjit, I'm not sure. I'll just message him.
I quote you an example. One of my surgical colleagues He's a very good colonoscopist, good colorectal surgeon. He performed a colonoscopy on the patient, took pictures of what he thought was either cecal, about the cecal, with the triradius forward, and everything was fine. Then I got called by a urologist colleague and said that, Wakar, can you come and see this patient? He's been scoped only a few weeks ago, but in fact, I saw that patient in my clinic after that, after the colonoscopy by my surgical colleague, and I told him that everything is fine and discharged him. And coincidentally, he ended up
better make up his mind.
with pain in the right iliac fossa. So they thought it was a renal colic because the colonoscopy was normal. So there's a neurologist CT scan on him. And on the CT scan, they found a big mass in the right iliac fossa from the colon. So he called me and said, you've been your patient, this is the problem. So I went to I saw the pictures of colonoscopy, and what I saw was sometimes when you are in the hepatic flexure, that looks like that triradiate forcing. And it is important that when you take picture of the cecum, you take a picture of the cecum both with appendix orifice and also the ileocecal bag. Because I spoke to the surgeon, he said, oh yes, I felt it was the cecum. So I said, well, obviously there is clearly the cecum because there was a mass there. But when you take, you should convince yourself that it is really the cecum, because a lot of the time, and I've myself been forced by it, I think, oh, I've got the cecum, and then when you twist it around a bit, you suddenly find there's more colon there. So always make doubly sure, because we were really lucky. That patient was picked up only a few weeks after he had been discharged. I discharged him from my clinic. So
he's doing this from home before
he goes
out.
the colonoscopy myself, but
It should be a good connection.
we would have ended up in a really shitty situation. So luckily, the urologist did a CT scan for a totally, it wasn't a urological indication, it was his ileocecal mass. So always be careful.
Are you ready for the next religious word?
Oh, sorry, is there a call?
Oh yeah,
Oh,
we've got 3 in a row.
oh gosh. You are a busy man.
Shut up, Radley.
Hi, Paul.
Hi Saeed, how you doing, my friend? Nice haircut.
Oh, thank you. Can you see me?
Hey, well, that's what I'm saying, nice haircut.
All right, good. Give me 1 second. Let me put my shared screen on.
Oh no, don't keep your shades on, my friend. Now, my friend, can you see the audience?
Yes, I can.
Right. We've got 2 of my eminent colleagues over here. This man works in Bangor.
Okay.
Hi,
This is Vakar. This is Saad Niaz. He's the chap who's been facilitating an awful lot of this.
Okay.
He used to work in the UK and they kicked him out.
for a good reason.
And the chap panning the camera is Sharia. He's actually one of the course organisers. And then this young lady sat down in front of me, Sajla, she actually is one of the major course conveners as well. In the audience, we've actually got a lot of the candidates. We have 5 candidates on this course, and then we have several observers. There's a couple of consultants who are also going to attend to listen to what you're saying. It's not putting you under pressure.
Oh, thanks.
But so what we're going to do is, I think the best way to do it is if we put the presentation up here.
Yeah, please, and I can switch through slides.
We will be able to pan the camera if you want towards the screen, and then you can say next slide, or you can just go through the slides yourself at home. Entirely up to you how you want to do it.
Okay, I'll probably say next slide.
Okay, so I'll just ask Sharia to get it up and move it on from there. Nice to see you, my friend, and thank you very much for doing this. Can I just get you to introduce yourself a little bit? I've already told them that you used to work with me a few years ago, that you've gone to Sheffield and that you're coming back to us shortly. Hopefully, say it's going to get a job as a consultant with us in the near future, within the next year.
Sheffield means that he's with
Stuart Riley.
no and
Matt
Basu.
Donnelly. Kumar Basu. Do you know Kumar?
Kumar used to work as an SHO.
Yeah, he was a first year registrar with me when I was in Leicester.
Yeah, he did. In fact, he did his house job and his SHO. I met him in.
No, he's the one on there, the polyp. He's Mr. Polyps. He's Mr. Polyp Man. That's him. He's the God and Guru on polyps. Now, what I'm going to ask you to do, Saeed, is just really talk about what you've been doing for the last 2 years, As I say, this is a chap who I believe knows an immense amount about polypectomy. He is an excellent colonoscopist. He's not a consultant yet, but he soon will be. But even, as some people would say, as a registrar, he's an excellent colonoscopist, and he will be coming and helping me on my courses and things like this. He's a chap who... Where are you from? Where's your family from, Saeed?
My family's from Pakistan in Faisalabad.
So, and that's where he's from. Okay. So he has a personal interest in wanting to see things do well in Pakistan. He's a chap who has felt very honoured about being asked to come and do a presentation. But please, when he's done his presentation, do spend some time and ask some questions. He's spent 2 years of his life working on a lot of this, and he knows an awful lot. So I'm going to shut up, which is very hard, as you know. And so we've got the first slide up, my friend.
Paul, I'll just introduce myself. My name's Said. I'm one of the research fellows in Sheffield. And as the gentleman rightly said, I do work with Kumar Bathu and Stuart Riley. And my research is mainly focused on looking at small polyps and simple interventions to improve polypectomy practice. And my research is coming towards the end now. But this presentation is just to give you an overview of simple principles of polypectomy, why small polyps are important, we know large polyps are important, and simple interventions that we can use to remove them and optimize polypectomy. So the first slide is just a base overview. So we know that colorectal cancer is the third most common cancer worldwide. There's a lifetime risk of 1 in 20 for women and 1 in 18 for men. Most polyps arise from the adenoma cancer pathway, and they can all harbor some form of malignancy. There's some suggestion that polyps that are less than 1 centimeter in size, the risk of cancer prevalence for these polyps is virtually negligible, but studies have quoted figures of at least 0.5%. Polyps that are greater than 10 millimeters in size, the cancer prevalence increases to up to at least 20%. So that's looking at the cancer prevalence for these polyps. But if you look at advanced adenoma for small polyps, sub-centimeter polyps, and polyps that are greater than 1 centimeter, then this underlies the importance why we should remove these polyps and prevent them from developing into cancer in the first place. So when I say advanced adenoma, I mean these are polyps which have got high-grade dysplasia, or polyps which have got a significant amount of villus component. So they're more likely to progress into cancer within a few years. So just to give you some figures, so polyps that are less than 5 millimeters in size, which are classified as diminutive polyps, the cancer prevalence, the adenoma prevalence is 20%. So these are advanced adenomas when you assess them histologically. Polyps that are between 6 to 9 millimeters in size, advanced adenoma is approximately 10%. And those polyps that are greater than 10 millimeter size, you can have advanced adenoma on histological assessment in 50% of these polyps. So that underlies the importance of removing these polyps. Polypectomy is one of the most commonly performed therapeutic interventions. And it's important that all endoscopists are able to perform these procedures safely and effectively, especially for polyps that are less than 2 centimeters in size. Paul, can we move on to the next slide, please?
No problem. Next slide.
Okay, great. Majority of small polyps that we encounter when we're doing colonoscopy are small. 90% of them are less than 1 centimeter in size. So just for the purpose of this presentation, diminutive polyps are classified as polyps less than or equal to 5 millimeters in size, and small polyps are usually classified as 6 to 9 millimeters in size. And anything above a centimeter is usually classified as large or very large, depending on the size. 10% of polyps are greater than 10 millimeters, and only 10% are 6 to 9 millimeters in size. So this just tells you how, when you do a colonoscopy and you find polyps, most of them are going to be small. But as we know, the risk of polypectomy or the complications increases with the size of the polyp. We know that from numerous studies, and a recent study by Matthew Rutter, who's one of the professors in Newcastle, has done a lot of work with looking at bowel cancer, the variation and complications. And the risk is 5 times higher in polyps that are 5 centimeters in size. But despite that, because most polyps are small and we're removing them more frequently, the complications tend to occur more for subcentimeter polyps. Paul, next slide, please.
Done. That's done.
Right. The things that we need to consider when we're doing a polypectomy is preparation of the patient. So there's no point doing a colonoscopy or polypectomy on a patient if the bowel preparation that they've had is suboptimal. There's various preparations that we can use. There's the polyethylene glycol preparations, which are osmotic laxatives, such as Moviprep. And then there's the sodium phosphate and magnesium citrate combinations as well, which is a combination of osmotic and stimulant laxatives. Patients who have poor preparation, the procedure will take longer, the patient will have more discomfort, and it also increases the risk of complications in these patients when you try to remove the polyp, especially if a perforation occurs. And it's important in these patients that we need to stop any iron supplements that they may take, because that will coat the mucosa of the bowel black, so you can't see anything anyway, and then they have to come back for a repeat procedure. And also, it's always a good idea to stop any constipating drugs as well. The constipating drugs doesn't help with the bowel preparation that they're taking in order to work. Next slide, Paul.
Oh, sorry. Done.
Okay, there's various methods that we can use to optimize polyp detection, and this is very important. Otherwise, you will miss lesions. Even large lesions can be missed. And as a general rule, and this is the general consensus amongst most endoscopists, colonoscopist experts, and numerous studies have been done, that the colonoscopy withdrawal time should be at least 6 to 8 minutes. And this allows us to have sufficient time to examine the bowel wall, look behind folds, change position of the patient, wash, irrigate, just to get a very good view of the bowel so we're not missing small polyps, just because of the risk of malignancy that they can harbor. It's always important that when your scope falls back to reinsert, and this usually happens at the folds, hepatic flexure, splenic flexure, and in particular, the rectosigmoid junction. And the rectosigmoid junction is one of the most common sites where you will miss polyps and you will miss cancers. And if you look at the studies, most interval cancers tend to occur at the flexures in the proximal folds of the colonic mucosa. You can give buscopan. There's numerous studies being done on buscopan whether it increases the adenoma detection rate. And at the moment, there's no general consensus of opinion. In my opinion, it does help with spasm, it does help with bowel distension, so I tend to use it as a matter of routine in most patients when I'm withdrawing, because it gives me better views of the bowel. And also when you're removing the polyp, it's much easier because the bowel's not as frequently going into spasm. Next slide, please, Paul.
Done.
Okay, you'll find that most polyps that we find are adenomas, 70% of them, and the remainder are hyperplastic polyps. Hyperplastic polyps are mainly encountered usually in the rectum, and if they're less than 5 millimeters in size and you're convinced that they are hyperplastic, you can leave them alone because the risk of malignancy in these polyps are virtually negligible unless they have a pearly white appearance and they're serrated. And that's a different topic in itself, having serrated hyperplastic polyps, because they have a higher risk of malignancy, and there's a lot more research being done on serrated hyperplastic polyps. When you see adenomas, they tend to look redder than the rest of the mucosa. They also may be normal in color and sometimes can be yellow in appearance. Hyperplastic polyps are usually pale, they're smooth, and often have small vessels visible on their surface, and they can disappear when you distend the lumen too much. Next slide, please, Paul.
Done, my friend.
Okay. The other thing we need to consider is whether the polyp you're removing is malignant or whether there's invasion. So always examine the polyp in detail. Is the polyp ulcerated? Are the edges rolled? Is there any surface irregularity? Is there depression of the polyp? These are really important. Is the polyp friable? Does it converge at the folds? Or is there expansion of the normal tissue adjacent to the lesion? All these things suggest that there may be underlying malignancy and invasion. Another important thing, I think, if there's anything you're going to take away from this presentation, is the non-lifting sign. I'm sure Paul's mentioned this. And the non-lifting sign is when you find a polyp, and you try to inject the base of the polyp and it doesn't lift, and then you need to seriously worry about malignancy and whether there's invasion. Also, occasionally you can get intense desmoplastic reactions and fibrosis when they've had a previous polypectomy and there's a recurrence of a polyp. But also, if you've injected a tattoo and it's actually gone underneath the surface of the polyp, so that tethers the lesion to the submucosal layer, so it won't lift. Next slide, please, Paul.
Sorted.
Okay. So before I start talking about the principles of polypectomy, I think it's important to mention in which lesions we do not perform polypectomy on. So I've already mentioned the non-lifting signs. So any lesions that do not lift, we don't perform a polypectomy. So you can always take a superficial biopsy. Take one biopsy, usually at the edge, and that can go to histological assessment. Too many biopsies will make that polyp very difficult to remove endoscopically because it tethers it down, and it will be extremely difficult for the endoscopist to remove that polyp. So I've already mentioned non-peduncular polyps, which if there are any signs of invasion. So any polyps that occupy greater than a third of the luminal circumference. So these are big polyps. You need experts to remove these polyps. And occasionally even the experts can't remove these polyps and they need to go to the surgeons. Any polyps that cross 2 haustral folds. And the most important thing about these polyps is if you can't see behind the polyp, trying to remove this polyp is going to be difficult because you're not going to be able to inject the polyp behind the fold. And you don't know whether it's malignant at the base or behind that particular fold. And any polyps involving the base of the appendix or the ileocecal valve, these are extremely difficult to move, and there's a very high risk of causing perforation in these polyps. And for these polyps, you're best referring them either to advanced endoscopists or surgeons. And it all depends on the patient's comorbidities, their history, and etc. Polyps that are very close to cancers, especially if it lies within the resection margin of the tumor, because there has been concerns in the past regarding tumor seeding to recent polypectomy sites, and this occurs via different mechanisms. There's various mechanisms proposed, such as the top-down approach and the bottom-up approach, where the crypt cells undergo proliferation and they travel down various pathways. Patients who have uncorrected bleeding disorders, because the last thing you want, you remove a polyp and your field of view is obscured because there's a spurting vessel, and then trying to control that bleeding can be extremely difficult in non-expert hands. Patients who take aspirin, clopidogrel, and then steroid anti-inflammatory drugs should be discontinued. This is mainly for patients who have polyps greater than 1 centimeter in size, or for patients where you're removing multiple polyps. Because there's numerous studies which have suggested that multiple polyps, when you remove multiple polyps, there's an increased risk of bleeding, especially if they're taking anticoagulation. And you tend to stop these medications 1 week before the procedure. Next slide, please, Paul.
That's done.
Which slide are we on now?
Removal of small colorectal polyps.
All right, great.
Patients.
Okay, I just wanted to mention this study. This is a very recent study which looked at polyps in anticoagulated patients. So at the moment, we don't know what the risk of cold snare excision while patients are taking warfarin. So in this study, they randomized 70 patients to cold snare polypectomy and hot snare polypectomy for sub-centimeter polyps. And they found that there was no delayed bleeding with patients who took cold snare polypectomy compared to 5 patients which required hemostasis who had delayed bleeding in the hot snare group. So there is some evidence out there which suggests that you can remove sub-centimeter polyps with cold snare excision, but I would err on the side of caution because there's not many studies done on this. What I generally find, if you have a patient who is on warfarin and you can't stop it, or they can't have any anticoagulation for some reason, if you do remove these polyps, please clip the base at the end. Then you reduce the risk of bleeding. Next slide, please, Paul.
Done.
Okay. So we're just going to go on to talk about the practical technique of polypectomy. So when we look at polyps, what are we looking for at the polyp we're going to remove? So I always think that actually during the polypectomy itself, the application of the snare or hot biopsy force is relatively easy. It's the preparation that goes beforehand, which is what we need to focus on, such as we need to examine the nature of the lesion. So what is the size of the lesion? Where is the lesion in relation to where your tip is? Is it in a fold? Does it cross a fold? Is it in one of the flexures? What is the morphology? Is it a flat lesion? Is it a depressed lesion? Is it pedunculated? Because some pedunculated lesions are not easy to remove, depending on the thickness of the stalk. And then again, I'm going to mention again the non-lifting sign. When we're removing these lesions, it's important that we get good luminal views. So we need to make sure that the bowel is adequately distended. You don't want to insufflate the bowel too much, because the patient will have discomfort, and then you find then you struggle when you are actually inserting your instruments through the channels of the scope. It's always important to wash the polypectomy site beforehand, so you can identify the resection margin, especially if you're performing cold snare polypectomy or hot snare polypectomy, because there's no point removing a polyp and you're not taking 1 or 2 millimeters of normal tissue with that polyp, because of the risk of incomplete resection and interval cancers. And also, as I mentioned before, change position if you need to optimize the best view to remove that polyp. And ideally, we should be removing polyps in the 5 o'clock position, because that's the position the accessory channel is on the tip of the scope, and that's where all the instruments will come through. And it's important, tip control is very important, and occasionally if you have a loop in the bowel, that will make your tip control very difficult to remove the polyp. And sometimes you can't remove the loops, and you need you need help from your assistants who will hold the shaft of the scope while you attempt to remove the polyp. It's always important to be familiar with the accessories that you use, with the snares that you have available, the diathermy equipment that you have, and it's important to be familiar with these settings, especially if you have assistants who are new or who are undergoing training or not experts. And it's important that you know how to mark the snare wire, because this will tell you how much tissue you've grabbed, especially when you feel resistance. And it also prevents snaring of the cheese wire when you're going to apply electropoultry. Next slide, please, Paul.
Yes, sorted.
Okay, and what I've found on a number of occasions with the endoscopists that I work, or trainees, communication is very important with your assistant. If you don't communicate well with your assistant, they will not know what to do. So it's important that your instructions are clear and concise, such as fully open the snare, half open the snare, or open the snare to the size of the polyp. Because sometimes you don't need to open the snare fully. Needle out, needle back. These are very clear, concise instructions that you need to give to the assistant, and repeat them if necessary, and ask the assistant to repeat them back to you. Most of the time they don't need to, but that's important. And once you've removed the polyp, this is a must. I would suggest when you remove the polyp, don't worry about where the polyp has gone. Always examine the polypectomy site for completeness of resection, for bleeding and any complications. I think endoscopists do this very poorly. And a recent study, the recent care study, suggested that we're not very good at doing this, even though they had incomplete resection rates of 10% using various different techniques and modalities. Next slide, please, Paul.
Done.
Okay, so now I'm going to move on to different techniques that we can use to remove polyps. So the first one is core biopsy forceps. This is a very simple and easy technique to use for diminutive polyps. You can get larger capacity polyps and jumbo forceps. These are a lot better. Core biopsy forceps will leave 60% of residual tissue behind. A number of studies quote figures up to 60%. So it's not very good at removing small polyps. If you are to remove small polyps, I would suggest you remove less than 3 meter polyps with cold biopsy forceps, and always examine the polypectomy site. A study by Lee et al. Compared standard cold biopsy forceps with jumbo forceps, and they found that the jumbo forceps left 17% of residual tissue behind. So still, that's not great, but it's better than standard biopsy forceps. As you know, with standard biopsy forceps, you will need to take 2 or 3 biopsies, and then once you've taken 2 or 3 biopsies, the views of the polypectomy site are usually obscured with blood, and then you're constantly washing, trying to assess if you removed the whole of the polyp, and then you get traumatic, you get trauma, you get edema, and it's very difficult to tell. Well, for polyps less than 3 millimeter size, I wouldn't worry too much, because the risk of these cancers developing malignancy is very small. Next slide, please, Paul.
Done.
Okay, so now moving on to cold snare. There's a few studies which have shown that cold snare is probably one of the best techniques to use for removing sub-centimeter polyps. It's safe, it's very effective, especially for polyps less than or equal to 7 millimeters in size. And also, you find that the incompleteness of resection is only 7 to 14%, depending on which study you read. And it's best to remove with sessile or flat polyps. There's different types of snares available. For small polyps, for sub-centimeter polyps, I would suggest that you use mini snares. So these snares are very good for manipulating the snare wire over the polyp, so you are able to grasp 1 to 2 millimeter rim of normal tissue. This is important. And you do this by, the V of the open snare should be positioned at the junction between the polyp and the adjacent normal tissue. So this allows you to capture a rim of normal tissue. With cold snaring, you don't tent the polyp. You apply pressure on the snare sheath, so you're kind of trying to press the polyp down in order to grab that tissue. And then when you close, depending on the snare you use, most of the time it's a hard, fast squeeze, and that will remove the polyp with a clean cut. There's different types of mini snares available. I've done a recent study where we compared the Exacto mini snare, which is a thinner snare than most conventional snares. It's 33% thinner. And in our study, we found that this snare, the complete resection rate of this snare was a lot superior than most of the standard snares, and with no risk of any complications. So I'm not promoting the company who makes Exacto, but this snare is specifically designed for cold snaring of small polyps. The only disadvantage of this snare is that you can't apply diathermy with this snare. But if you need to apply diathermy, you shouldn't really need to apply diathermy for small polyps. If you're worried about the risk of bleeding, especially in the right colon, then you can apply a saline lift in the right colon. Remove the polyp with a standard cold snare, and then you can clip it afterwards. And I've done that a number of times in the past. So you're not even having to make up the EMR. It makes a simple saline solution to lift the base of the polyp. You remove it using a standard cold snare, and then you clip it afterwards. Next slide, please, Paul.
Done.
Okay, so hot biopsy forceps. I'm not going to talk too much about hot biopsy forceps. I don't know if you use a lot of hot biopsy forceps. I've never used hot biopsy forceps in my practice, and most endoscopists, most experts don't use hot biopsy forceps anymore. This does have a better completeness of resection rate compared to standard biopsy forceps, but there's a risk of delayed bleeding and perforation. So I'm not going to talk about hot biopsy forceps too much, because I don't think there's any role for this in polypectomy anymore. All right, swiftly moving on, Paul.
On to hot snare, my friend.
Yeah, thank you. Okay, the principle of hot snaring is very, very similar to cold snaring up to the point of closure. The only difference with hot snaring is that when you grasp a sessile polyp or a flat polyp, you tent it away, and when you're applying diathermy, you get the whitening of the sign when you're applying coagulation or cut. That's the main difference between hot snare and cold snaring. And you mainly use hot snaring of pedunculated polyps in the left colon, and you can use this with or without injection, depending on the thickness of the stalk. Most experts will recommend using low power settings, 15 to 25 watts. In my practice, I've rarely had to go over 30 watts of power. And also, the other important thing is, I don't know, some endoscopists prefer squeezing the snare themselves, and some prefer the assistant to squeeze the snare. I think when you squeeze the snare yourself, you have a lot more control over the squeeze pressure. And I think that's a more important determinant of tissue heating than both the time and power setting when you're applying electrocautery. And therefore, when you're squeezing the snare, you should exert firm squeeze pressure during the application of cautery current, and that kind of gives you an idea how much resistance, whether it's cutting through the polyp or not. Otherwise, you'll have an assistant who will squeeze through quickly, and then you will get bleeding and the electrocautery is not worked. Okay, moving on, Paul.
EMR, my friend.
Okay, so
this
EMR
particular
involves...
group they're really not at the stage of EMR, so it might be best just to skip through as much as possible on this bit.
Okay, I'll just briefly go through EMR.
Sorry, my friend.
EMR just involves injecting the base of the polyp to lift it away from the muscle layer. This is just to reduce the risk of bleeding and perforation, and also to prevent electrocautery from cooking the tissue deeper down. That's the main principle of EMR. It's not a very difficult technique to learn, but it requires a lot of skill in terms of injecting the polyp in order to lift it, and where you inject the polyp to lift it so it makes a kind of a dome shape. There's different mixes that you can use with a combination of gelafusing, adrenaline, and indigo carmine. But there's a whole separate topic on EMR and ESD. So I'll just move on to some of the tips when we're carrying out simple polypectomy. Paul, next slide, please.
Next slide.
Okay, these are just useful tips I find that help when I'm carrying out polypectomy, or what I've learned from my trainers. I think when you're doing a colonoscopy, it's always important to remove the small polyps, especially the diminutive polyps of between 5 or 6 and 9 millimeters on insertion, because you will get to the cecum, and when you withdraw, you won't be able to find some of these polyps. If the patient has a lot of polyps, occasionally, due to discomfort, you can't remove all the polyps in one sitting. So it's always worthwhile to clearing the right side of the bowel in one sitting, and then bringing the patient back to clear the left side of the bowel in the next sitting. Large pedunculated polyps are best removed by hot snaring, and you apply the hot snare at the mid portion of the stroke. And the reason for this is, if that polyp is malignant, you want to take at least a good margin of normal tissue. And plus, if you cause any bleeding complications, you want to be able to grasp that tissue afterwards or apply a clip. So that's the advantage of snaring at the mid portion of the stalk. And it depends. And some stalks are extremely thick. I've come across stalks that are 1 centimeters. And for these stalks, if you have an endoloop or clips, you can apply those or apply injection to reduce the risk of bleeding. And that does happen. Next slide, please, Paul.
Next slide.
Okay. As I mentioned, large sessile polyps are mainly removed by EMR technique. The idea is to remove the whole polyp in a single piece, and this can mainly be done for polyps that are less than 2 centimeters in size. For polyps greater than 2 centimeters in size, sessile polyps is extremely difficult, and usually you end up removing the polyp piecemeal. But you still need to plan what portion of the polyp do you remove first. So sometimes you end up bisecting the polyp, removing it in 2 pieces or 3 pieces. But the most important thing is to take your time to remove these polyps and to make sure you don't leave any residual tissue behind. And always be aware of any discomfort you're causing the patient. Because if the patient starts having severe discomfort during the polypectomy, then you need to think about whether you've caused a complication, especially perforation. When you're carrying out any form of polypectomy or removing numerous polyps, they can be time consuming. So it's important that you allocate sufficient time when you're carrying out polypectomy, because you can have a really busy list, and you're rushing, and that increases your risk of having complications. So if there's not enough time to remove the polyps, then it's important that you just bring the patient back and you allocate a double slot to remove these polyps. For flat and depressed lesions, I would suggest that you always remove them by a saline lift or endoscopic mucosal resection. Next slide, please, Paul.
Tattooing.
Yeah. So when you're tattooing is important. The reason we tattoo, if the patient requires surgery or surveillance in the future, and you usually tattoo for polyps that are not resectable, those polyps that are malignant, and large polyps. Any polyp greater than 1 centimeter, I suggest you should tattoo, and usually tattoo distally from the site of the polyp, usually 1 to 2 centimeters, and at 3 points. So if you need to do a surveillance colonoscopy in the patient, you can assess that. You can identify the polypectomy site, look for any scarring, and make sure there's no recurrence of that polyp. And that's important. That's the reason we tattoo, and we do it quite often. And tattooing is a very simple technique, very similar to applying EMR. Some endoscopists actually apply a saline bleb first, then inject the tattoo in there. This is to prevent the tattoo from going into the submucosal layer and into the peritoneum. Next slide, please, Paul.
Done.
Okay. As well as carrying out polypectomy safely and effectively, it's important that we retrieve the polyp. Polypectomy retrieval rate should be over 90%. That's relatively easy when you're performing using a biopsy forceps, but it can be quite challenging with hot snare, cold snaring, especially for small polyps, because sometimes they can get lost in the suction channels, sometimes they fragment. And the reason we need to retrieve these polyps so we can classify them and exclude any malignancy Most polyps tend to remain at the site of the polypectomy site or adjacent to the resection site. Occasionally, when you've lost a polyp, it's worthwhile injecting some fluid down the channel and then follow the fluid, and that will tell you where the polyp has gone. And then you just suck in that pool of fluid and you will retrieve the polyp. I would always recommend that even if you're removing large polyps, either piecemeal or non-piecemeal, always attach a polyp trap. Because if you're performing piecemeal, there's lots of small fragments of tissue that break off, which you do want to collect for histological assessment. Because if you can't find the large piece, at least you've got some small fragments which they can assess histologically to exclude any form of malignancy. Occasionally, you may need to change position to reveal a lost polyp. And large polyps, greater than 1 centimetre, usually you need a rough net to collect them. Next slide, please, Paul.
Complications?
I'm not going to go too much about complications and follow-ups. The most important thing, I think, when you are removing polyps is always assess the polypectomy site for bleeding or perforation. If you think there's excessive oozing at the polypectomy site, I would apply a clip. It's very simple. You don't need to worry about delayed bleeding, although it can happen in some circumstances. And it's important that you give instructions to the patient on what to look out for delayed bleeding, such as rectal bleeding, like a dripping tap when they go to the toilet, any severe pain, any localized pain that they may get. And also, as part of removing polyps, it's important that surveillance is an essential part of the management plan. Next slide, please, Paul.
And we're on a polyp on an EMR, my friend. Just really say this group is not at this stage, but I'm more than happy to go through the pictures. But
yeah, I was going to send a video because this was quite an interesting polyp. Yeah. So I'll just quickly go through the pictures and we can finish off then.
No problem, my friend.
Okay, so the first picture, if you look, this picture is of a large ascending colon polyp. If you look at the picture of this polyp carefully, it's about 3.5 centimeters in size, and at the proximal area, it looks slightly depressed. So in order to examine this polyp in a lot more detail, we injected this with some EMR mix. Are we on the next slide now, Paul?
Yeah.
Yeah. So my pictures aren't great because I've got a pic. So as you can see from the second picture, I think, am I injecting here, Paul? Am I applying the snare now? I can't see.
Yeah, you've actually just got the blue ink, and you can see that we've got some slight difference in colour.
Yeah, okay, that's fine. So in the next few slides, what we're trying to do is inject this polyp and lift it to see that it does actually lift. It's not tethered to the submucosa or mucosal layer, and there's no invasion of malignancy. So, Paul, I'll let you just go through the slides.
And we're just lifting it now, my friend?
Yeah, so we're lifting the polyp, then we apply the snare to remove it.
Now you
so
have
if you
the
go
snare.
to the, yeah. So as you can see with the snare, we've grasped some tissue. Have you got to the bit where we've grasped some tissue?
Yes.
Okay, so we grasp one tissue, then we apply hot snare, and we remove this polyp piecemeal. You can't remove this polyp in one piece. If you attempt to do that, you will cause a complication. So this polyp was removed in about 7 or 8 pieces. It's quite a large polyp, and we prevented this patient from having surgery. When we go to the, Paul, if you skip to the last slide of this polyp.
Last slide.
Yeah, so on the last slide, we can see, if you look at the base of the polyp, you can see there's no perforation here at all. But if you look at the edges of the polyp, we've actually applied APC just to make sure we haven't left any residual tissue behind. And you can apply APC because that reduces the risk of incomplete resection. But this was a very large polyp. This needs to be removed by one of the advanced endoscopists who have lots of experience in removing these. But then the most important thing about removing this polyp, this was removed in 8 or 9 pieces. We allocated over an hour to remove this polyp, which was more than sufficient time. But the other important thing is this patient will come back in 3 months' time to assess that we haven't left any residual tissue behind and there's no recurrence. And then we'll give them advice on any risk of bleeding or perforation and what to do in the event of that. I think that's it, Paul, in terms of...
it is, my friend. I found that very interesting. I don't know, anybody in the audience? Well, we've got a lot of people nodding. Have anybody got any questions?
I'll extend everyone in silence.
We have... We do have some questions, my friend.
Okay.
I have a question that, as you said before, that the polyps that has got certain kind of stalks that should be cut at the midpoint of the stalk.
Yeah.
So, is there any chance of recurrence of those polyps, or how often should we follow up those if we have got such kind of polyps that has got a stalk and we cut it from the midpoint?
Okay, that's a very good question, because the whole idea, usually the stalk of the polyp is usually normal tissue, so it hardly has any dysplasia in the stalk. So the reason of cutting at the mid portion is so you're taking a good margin of normal tissue, and it's usually the apex of the it's usually the apex that's most likely to harbor any dysplasia or malignancy. And when they examine the polyp on histology or pathology, they will tell you whether they've got a clear excision margin. And if the sample comes back that you haven't removed it completely because they've had a look at that stalk, then you need to go back and remove the remainder of that stalk. So, and the advantage of removing the mid clip it afterwards. Does that answer your question? So it's usually histological assessment will let you know whether you have a clear excision margin or not. If not, you repeat the colonoscopy and remove the remainder of the stalk. But you need to be careful then.
So, what is your opinion on a follow-up colonoscopy with regards where you question whether it has been completely excised or not excised? How soon would you repeat one?
Sorry, for which one?
Any polyp that you question that you've done piecemeal or question has it been incomplete?
It's usually 3 months' time. Usually, we tend to bring patients back every 3 months, especially for large EMRs, just to check the polypectomy site. Because they might need a recurrent treatment every 3 months to remove the residual tissue. And some polyps that we remove piecemeal, when you look at the studies, they do quote interval cancer rates of up to 30% for some of the large piecemeal EMRs. So I think every 3 months is usually gives enough time for the patient to recover, for the site to heal, and then to bring the patient back so they can tolerate the procedure for the second time.
Excellent. I'm going to introduce you to Dr. Ali. He's got a slight roguish smile on his face, so it might be a trick question.
How are you saying? I'm Dr. Ali. What's your experience about the juvenile polyposis syndrome? We've got few patients, so we are just stuck with them. What's your experience about that?
Well, in Sheffield, what we do, patients who have polyposis syndromes, we remove some of the polyps, we send them off for histological assessment, and these patients have genetic testing as well. And if we find that they have a true polyposis syndrome, they usually have either a colectomy or subtotal colectomy, and they usually go to the surgeons. That's usually our practice. However, if they have a polyposis syndrome, and depending on the number of polyps they have, the polypectomies are performed endoscopically with chromoendoscopy. So you use indigocarmine, they have regular surveillance, and all the polyps are removed on an annual basis, depending on the suggestions of the genetic counselors and how often they should have the procedure. So practice varies amongst different units in the UK. But as a general rule, if they have a true polyposis syndrome, you have a consultation with the patient. If they're happy to have a colectomy, subtotal colectomy, they get referred to the surgeons.
All right. How frequent do you call them for polypectomies if you go for the polypectomy schedule? You were what you're saying.
Patients who are high risk usually have it annually, and they have it with chromoendoscopy. So indigocarmine is quite healthy. It's quite messy when you use indigocarmine spray, but it does highlight lots of areas of the bowel which you can't see with standard white light endoscopy. There's a recent Cochrane review that we've done which showed that indigocarmine compared with white light endoscopy is a lot better at picking up adenomas, and for patients who have polyposis syndromes, and in patients who have when you're looking for dysplasia in patients with inflammatory bowel disease. So and that's another tip I would suggest, that if you do remove polyps and you find it difficult to identify the margin of the polyp, a few drops of indigocarmine will help. And I usually use a dilution of 1 in 8, so 5 mils of indigocarmine ampule diluted up to 40 mils of sterile water or normal saline, and you can just wash that down the endoscopy channel, and that usually helps. And I've started doing that a lot more when I'm looking to see if I've completely removed the polyp. So to make sure my polypectomy site has been completely resected and I've not left any residual tissue behind. And we have done a study to look at completeness of resection using different techniques and different devices, which are going to be published very shortly.
All right, thank you. Can I have another question, sir?
Have another question?
Yeah, I've got another question. Post polypectomy, if you got a bleeding,
Yeah.
after how many procedures or endoscopic maneuvers will you send the patient for surgery? If you're
Sorry,
still,
can you
if the
repeat
patient is
that?
still bleeding after endoscopic management, if you have applied endo clips and everything you have done.
Paul, I don't know if you.
What he's asking is how many repeat colonoscopies would you do if you've taken off a polyp and then the site continues to bleed despite the endoscopic management, then you go back in, how many would you put the patient through before you would repeat? Oh, gone. You get one chance and you're out.
Basically, third.
What's gone? Have we used all the time that they're going to give us? Saeed?
Got you back.
Sorry about that, my friend.
Repeat that last question.
So the last question was, how many times would you put a patient through a repeat colonoscopy who's had a polypectomy and they're bleeding from the site and you offer therapeutic endoscopic treatment? So would you, once you've taken off a polyp and bleeding occurs, would you do a colonoscopy? And then after that one, would you repeat it if bleeding was still to continue?
Well, that's quite a good question because there's no general consensus on how many times you should repeat the colonoscopy to achieve hemostasis. And as a general rule, most of the time it would be performed usually once or twice after the initial polypectomy. And if that fails to control the bleeding, then you go down the route of CT embolization or the surgical route. So it depends whether you can get control of the bleeding. And most of the time, you should be able to get control of the bleeding on the first repeat colonoscopy. And if you can't achieve it, then it's very unlikely you're going to repeat it. You're going to achieve that on a repeat colonoscopy. And what we've done generally is sometimes what we do is you apply clips at the polypectomy site, and that clips act as a marker when the radiologists perform a CT scan, CT angiogram, in order to embolize the vessel which supplies that area. And that usually, and then they can embolize the area. If that doesn't work, then the patient usually goes down the surgical route. It's very rare that happens. It's very rare in practice in the UK that we've had, major bleeding complications which go down the route of CT embolization or surgery. And it usually happens for polyps that are usually malignant. And that's another important thing to bear in mind. So it's always worthwhile at the time, if they have bleeding, to get the histopathologist to tell you whether that polyp was malignant or not. And if it is malignant, then going down the surgical route is probably appropriate, so they can have colectomy.
Thank you. Thank you. So nice of you.
So I'm just going to... Got any questions, sir? No? So thank you very much for your time, my friend. I really appreciate it, and I'll catch up with you when I get back over.
Yeah. All right. Thank you, everyone. Bye-bye.
Thank you. One of the other reasons why you have bleeding is you haven't got the polyp properly. A nice pedunculated polyp, and instead of getting the whole polyp, you actually taken half the polyp out or three quarters of the polyp out, and obviously you're going to end up having problems. But in our experience, we have, since I've come back to Boston, I didn't do any in the UK. I've never sent a patient to a surgeon for a bleeding polypectomy. In fact, so far I've been very lucky to not have any significant.
I'll ask her just to speed through it if that's all right, because she'll be grateful of that. Now the last one that we've got is someone who's actually done a comparison between bowel cancer screening service and the standard service in the UK. and what I'll do is get her to come on, and then she'll be pleased if I ask her just to speed through it, because she will be relatively quick. It'll trip her up, but this is Lorraine. She'll be nervous as you can't believe.
Hello.
Good morning, Lorraine. It's Paul. How are you doing?
Hi, are you?
I can see
Bear
you.
with me can you bear with me 1 second?
Oh, here we go. She's probably putting the dog out. It's not a dog, it's a rat. It's this big. I'm just telling everybody you're probably putting your dog out.
Sorry.
No, it's no problem. Loz,
Hey.
sorry to put you under a little bit of pressure, but we're under a little bit of pressure for time. Are you okay to do this in about 15 minutes, 10 minutes?
Yeah, that's fine.
That's fine. I know that'd suit you. That makes you happier. So I'm just going to introduce you. This is Lorraine. She's lead for gastroenterology endoscopic training at Nottingham City Hospital. She trains throughout the UK and teaches on an awful lot of courses. She's very influential. She's also been made lead for bowel cancer screening under the Nottingham service now. And what we've asked her to do is do a quick presentation which makes her happy, and on which she's recently given in Japan. So she was flown out to Japan and do this. So just really to give you a synopsis of what she did out in Japan. So Lorraine, if you say next slide, what we'll do is just roll to the next slide, etc. I'll let my friend
Okay. I'll try and whip through this as quick as possible. It's a bit longer than 15 minutes, but I'll miss some slides out as well, if that's all the time that you have. Is that okay, Paul?
That's fine.
Okay. So the next slide, what I thought I'd do first of all is just tell you a little bit of a few statistics from the UK. In the UK, the biggest incidence of cancer is breast with the second lung, and the fourth is bowel cancer. We have a higher incidence amongst males at 56%, and if you look at the lifetime risk, it's 1 in 14 for males and 1 in 19 for females. Interestingly though, in terms of death, bowel cancer accounts for 10% of all our cancer deaths in the UK, and is the second cause of cancer death, although there are more male and female patients with breast cancer and prostate cancer. Next, Paul, sorry.
Done.
Are you on the slide with the two graphs on?
There's one graph saying cancer mortality 2011, still
Yeah,
low.
next slide.
I've got two graphs.
Sorry. There's two graphs.
Two graphs.
Yeah. This graph, what the top graph shows is the incidence of bowel cancer in the UK, and the top graph shows that we have an increase in incidence, and the bottom graph shows our mortality rates are actually dropping. And this is since, these statistics have been collected since the early 1970s. And what we actually think is happening is we do have an ageing population, and we have 73% of our bowel cancers are in the 65 and overs. And so that could answer the question for the top slide. But I think in terms of mortality, we're actually getting better at detecting colorectal cancers, and our investigation's better. If you look at the studies from the early 60s, their completion rates for colonoscopy was only about 50%. So we are getting better at what we actually do. And we've got a significant drop in the 2000s, and that's maybe since the introduction of the bowel cancer screening programme. Next, Paul. So why should we have a national screening programme for bowel cancer was the question. And we know that 95% of colorectal cancers come from polyps in the bowel. And if we can nip that in the bud at an early stage, then we're going to prevent that cancer from actually occurring. So that was the idea behind this, because it gave us a window of opportunity for early detection and prevention. And so we thought they thought it was a good idea to have a national screening programme. So next, Paul. The next slide shows where we were in terms of detecting cancer before the bowel cancer screening programme. And like I've already mentioned, we want to detect these cancers at staging Dukes A and B, so in the early stages. But we weren't doing so well at that. We was only detecting just under 30% at stage A and B. And the remainder was at the later stage where there was a greater risk of death. So we weren't doing that well before the bowel cancer screening programme. Next, Paul. So what we actually do is we send the patients, there was a number of studies. The first one, I think the one I've got on the slide, is from 1996. And this was done in Nottingham, our hometown in England, across at our other hospital. And they recruited quite a large number of patients into a study, and they sent them fecal occult blood testing. The one problem is with fecal occult blood testing, it's not necessarily specific to human globin, and it can detect all sorts of other food products as well, which we are aware of. So it's not foolproof, but what it did prove is that it can reduce colorectal mortality by 16% by identifying these patients for colonoscopy. So that was, and there was 3 other studies, one in America, I think one was in Sweden, just bear with me, and the other one was in Denmark. And these all came up with similar figures. By sending patients fecal occult blood tests was a gateway into colonoscopy. I'm going through this quite quickly because I know you
Not a problem,
constrained.
not a problem.
So the next thing that they actually did before they, next slide, Paul.
Yeah, well, on feasibility.
Before they went ahead with the national screening programme was to test the feasibility and acceptability of the public using fecal occult blood tests at home. And there was various pilot studies. They did a similar study to the Hardcastle study, and aimed it at people between 50 and 69. There was quite a good uptake, almost 60%, although it was lower amongst men, younger people and people of deprived areas and ethnic origin. And out of all the people that were screened, 82% that were positive, 2 out of those went on to 2 out of 100 went on to colonoscopy. And the detection rate for colorectal cancer, this isn't polyps removed, was 1.62% per 1,000 people. But what was interesting is that there was more people detected their cancers at an earlier stage at Dukes A and at Dukes B, so 48% at Dukes A. So that was the pilot study. So the next slide shows how we actually deliver that service. We have 5 hubs in the UK which send out the little kits to test for fecal occult blood, and these link to 20 screening centres across the country. And so far, well, that number is from the beginning of this year, so we've sent over 20.5 million kits out, and over 50% have been returned. About 90 out of every 100 are negative. There is an equivocal group in the middle, which we retest, and if there's any doubt there, then we treat that as a positive, and about 2 in every 100 will go on to have a colonoscopy, as already said. Before they actually come, and this is where we're getting into the debate of having a 2-tier system with our colonoscopy. In the next slide, the process of delivery, it shows you what we actually do. And all patients that are found to be positive see one of our nurse practitioners who actually go through everything with the patient, they coach them through the bowel prep, and then they come to colonoscopy. If everything's normal, they'll go out of the pathway and they're sent another fecal occult blood test in 2 years. If they have a cancer, they go down the cancer pathway. If they have polyps, we put them into a surveillance programme dependent on how big those polyps are. With a nurse specialist service, what they do is they coach their patients through their bowel prep as well before they have it. So that we know that their bowel prep is much better than our service patients that are symptomatic. So that's the first difference in our services. So we are creating a 2-tier service. If we look at our, this is just miss the next slide, Paul.
I've gone to Duke staging.
So Duke staging, if we go back to our Duke staging, the first line shows our non-cancer screening patients. And like I said at the very beginning, less than 30% present with a Duke's A and B, where if you look in the screening group, we're looking at over 50% there are diagnosed at an earlier stage, so the survival rate is much better. So we know that the bowel cancer screening programme does actually achieve what it set out to do, was to save lives from bowel cancer screening. The next slide shows about our quality assurance, and basically with our colonoscopy screening, once you're signed off, you can do your diagnostic tests. It's very different to be a bowel cancer screener. Not everybody can be a bowel cancer screener. They're almost, as I would put it, like Paul, the elite. They are people with a lot of experience in colonoscopy. They go through training and mentorship. They have to have their colonoscopy assessed and critiqued, and then they have to complete an exam paper to show that they know exactly what our guidelines are, what they're looking at. All our equipment is specific, and the patient has more time for their colonoscopy as well. So obviously if you have more time to look at a colon, the more chance there is of finding something. Throughout the colonoscopy, data is collected. That's not collected on our service list, which looks at the colonoscopist performance, the procedure itself, whether they are completing the procedure, adenoma detection rate, and the length of time it takes to withdraw the scope. What is very common in service lists is the time constraint, so often scopes get removed very quickly. Within bowel cancer screening, they have a target of 6 minutes. It should take at least 6 minutes screening on withdrawal, but they are aiming to increase that to at least 8 minutes. So I'm not sure what time you give for your colonoscopies over there. And then the other thing is all their data is shared regionally, locally, regionally and nationally. So there's great transparency, nothing is hidden. So all these colonoscopists data is there for everybody to view, so everybody knows how these colonoscopists perform. Again, that's very different to our diagnostic colonoscopists on service lists. The next slide, we can skip through the next slide, Paul.
I've got a picture of Brian.
You got a picture of Brian? Okay, I don't know whether Paul's already showed you this. Nationally, we have something called the Joint Advisory Group, and all our trainees' colonoscopy gets put into a database via this website, and it's got stringent training rules, and you have to achieve various levels. So, for example, you have to be achieving a 90% completion rate, reaching CECM before you can get sign off. You have to have attended various courses. You have to have been assessed by 2 other people other than your primary trainer to get sign off. That's just to become a diagnostic colonoscopist. Next slide. The next slide is again a quality assurance slide from one of our screening colonoscopists, and these are all the measures that he is put under and what I've already mentioned. And also the other things they look at is comfort score and how much sedation you're using, and if you use reversal as well. If your scores start to fall into the red zones, which are below what is the achievement standard, then your practice is actually questioned. They will look at that practice. You could even have reassessment, or your practice as a bowel cancer screening colonoscopist could be stopped, basically. Is that true, Paul?
It is. There's 3 chaps already nationally. One major name, which I'll tell Saad later, who's been suspended pending review.
So it is quite strict, really, in terms of there's lots of pressure in being a screening colonoscopist than being a diagnostic colonoscopist on our lists. Next slide is about bowel scope screening. So we have got an age extension because originally our cancer screening program was aimed at the 69-year-olds, and it's now 60 to 69. But what they're introducing in the UK at the moment is the bowel scope screening flexi-sig program aimed at all 55-year-olds. And basically, they will be invited to attend for a one-off flexi-sig. If they found to have polyps, they'll go on to have a colonoscopy. And it's thought that lots of data has been collected through the colonoscopy screening program, and it suggested that 60% of cancers were found in the distal end of the colon, and that's why they've decided to go down this route. And again, 62% of cancers in the pilot studies have been Dukes A and resected at flexible sigmoidoscopy, so polyp cancers. The next slide talks about a new test. Because fecal occult blood testing is not so specific and there's a lot of false negatives, they're now looking at a new test called fecal immunochemical testing. And basically this is better at detecting heme, and so there's less risk of false positives, and hopefully this will have an impact on the number of colonoscopies that we're actually doing. And this is again in its pilot stage. Our Department of Health in 2011, and this, I don't know how quick or slow things happening over there, made a statement that it was going to do a pilot, and as yet this pilot, as far as I'm aware, hasn't taken place, and we're in 2014. So in summary, the bowel cancer screening programme and the National Bowel Cancer Screening Programme does reduce mortality, but fecal occult blood testing is non-specific. I'm not quite sure of what its use is in bowel cancer screening, other than the fact it's a gateway to get people into having a colonoscopy in the bowel cancer screening programme. I think we're in great danger of creating a two-tier service to the patients, which does affect quality for patients that are symptomatic, and I'm sure in the future that will come into question. And in fact, I'm not quite sure whether we've got 2 tiers or even 3, because we have our diagnostic endoscopists, we have our therapeutic endoscopists, and we have our screening endoscopists. And we have to choose tools that are suitable to our public as well, and what is acceptable for them. Thank you very much.
Lorraine, that was excellent.
Paul?
No, that was beautiful, darling. I only did it so that you would actually be put under pressure, and also I know you can wobble on, and you need to get back to Ted. Ted's the dog. So I just
Ted is the dog. I've put him outside.
Can I? And now what I'm going to do, Lorraine, I'm just going to open up to a few questions. I've got Saad Niaz. He's the chap who facilitates all these courses. He's the main instigator and reason why I'm here. So you can say hello to him, and don't say he's handsome.
He's very handsome.
Lorraine, thanks for taking time out and giving this wonderful talk. Very informative. Just a quick question. If you move from the standard fecal occult blood testing to the FIT, how are you going? I mean, the cost would be very different, I gather.
The cost is going to be phenomenal because it's so much more expensive.
And with the hundreds and thousands that you've been, or in fact 2 point some million that you had sent when you change it to FIT, and that's one of the problems we had, because we were going to be part of a group. We have an Asian Pacific colorectal cancer group, which I'm part of, and we just did a screening. They've actually just published it. I think it's probably in the gut, or it should be. It's been accepted in one of the journals, but we couldn't be part of it because FIT is not available here, and they would not take FOB's standard occult blood testing for their study. So I was just wondering, because the cost was so much, we just chickened out of it.
I think one of the things during the pilot, what will be looked at is cost. And historically, if you go back and look at all the studies in terms of screening, cost has been an issue. The other thing is resource in looking at these kits as well. Ideally, in any screening program, we should be offering a colonoscopy. Fecal occult blood testing, even itself, you could question, has a cost attached to it, and we know it's not foolproof. And could we cut cost off screening by not sending out a fecal occult blood test and going straight to colonoscopy? But then you have to think about what resource you have to do your colonoscopy. So, you know, there's lots of swings and roundabouts here. It's resource, it's cost, it's what is acceptable to the public as well. And as yet, until we get the results from the pilot study, we don't even know if we'll go down the result of sending the patients the FIT tests.
And the rare breed of the elite colonoscopist is not going to be not going to be very easy to maintain, because you will have more and more demand. Because I mean, obviously, if you have 3 tiers of colonoscopists, it is going to be difficult. The pool would be, if I was to have my colonoscopy, then I probably would want to have it done by somebody who's doing who's part of the national screening program.
You would,
because
and I would choose my colonoscopist as well.
Yeah.
And if the public knew that there was such a 2-tier system, which the public aren't aware of this at the moment,
well,
but
very
I'm sure
soon they will be.
In the future this will come out in the UK that this, you know, if I present with bloody diarrhea, I'm going to get a basic colonoscopist.
Yeah.
But if I'm walking well, which seems a little bit ridiculous really, I'm going to get an expert colonoscopist. Yeah. It's just a little bit mixed up, and I think there's a lot of work to do here really. But I think give it 5 years and things will change yet again. Somebody will start publishing all this work in the UK. But as yet, it's not in the public domain.
Well, I think I'd congratulate you for what you've done and what is being done in UK. And I'm sure where you've come from in the last 20 years, I'm sure there must be things that you can do to bring everybody at par with almost the screening colonoscopist, and that's probably one way out. So you would get rid of the tier system and get everybody else to that level. You've already done kind of 60% of the work with the cecal intubation, etc. So it's just standardizing. Well, thank you very much once again for being with us and taking time out. On behalf of everybody here, thank you once again.
Thank you very much for inviting me to speak.
Lorraine, you were absolutely brilliant. See you, sweetheart. See you when I get back. See you got your glasses.
That's to make me look professional.
Oh, no worries, darling. See you soon.
Bye.
Bye. She liked you.
Do they have a
I hate you. She liked you. I can tell.
But do they have a place in Nottingham?
You don't want to work in Nottingham.
I don't mind working
You
anywhere.
don't want to work in that. Like her. Do you know, she was just winding up. You were just that second away from actually getting to go full flow, and then you'd never shut her up. You were so close.
Because I think the couple of things that were highlighted here, if you are going to embark upon a screening program with people who are actually doing screening programs, the problem they're facing is this acceptability of the population you want to screen. The risk within that population that should be established. You should have acceptability. There's no point setting up a screening program and you find out 10 out of 20 patients say no, we are not going to have any tests done. And then finally, last but not the least, if you are going to offer screening, the colonoscopist has to be the best. If you're not amongst the top colonoscopist, screening program is really not worthwhile. That's what the message was. Correct me if I got the gist. And so they are saying that people who had done thousands of colonoscopies, who had cecal intubation rate of over 90%, were stopped from screening colonoscopy because they did not achieve certain other parameters that are part of screening program. So if we tomorrow decide to start screening, we need to ask ourselves, Are we there? And if we are not, are we really helping our patients? And if we are not, will we be justified? Are we justified in doing what we are doing? If we are not, then we are doing something wrong. It's very easy to call everybody else and everybody in all other professions corrupt, and especially the politicians and whatnot, the police and the customs. We need to look at ourselves, and this is corruption, because you've got evidence from people who are doing it. So if you want to do it, you already have a benchmark. You either reach that benchmark and then do it, or practically you be honest and say, well, look, I'm doing a colonoscopy, but I may be missing something, right? So that was thank you very much, Paul, for getting these people over. Obviously, the talks were really excellent. The polypectomy was very comprehensive.
Just listen about the polypectomy. What he was saying is more complications are had with the diminutive ones, small polyps, than the larger ones, because the larger ones are normally tackled by more experienced
I think one of the fears that I've seen in people is that if you're taking a small polyp out from the right colon, then if you're going to snare it, just snare it cold. Small polyps, wherever they are, they can be snared cold. You don't need to use diathermy. You don't use diathermy on the right side, you're not, or what Dr. Vakar showed just yesterday or day before. All the things about diathermy and the effect and the risk of perforation goes away. Okay, so I think small polyps don't need to be snared with, don't need to be hot snared.
No, and that's what he was saying.
And that's what has been shown.
He's the gatekeeper to all the
In fact, this
data.
trial that he mentioned in the American endoscopy journal, GI endoscopy, that showed that even patients who are on anticoagulation, warfarin. Now, they were showing that the risk is not significantly high. So the risk of bleeding is also the way you do polypectomy. If you take a nice polyp out halfway from its head, don't blame the polyp, don't blame the snare, don't blame the coagulation, blame yourself. And it's very important to have good view. Do not perform polypectomy if you're not comfortable with your view. Change the position, change the scope, remove the loops, all that. Then go for polypectomy. You must not do it if you don't have very clear polyp view. The rest is experience, reading, seeing. Today's world, you can go and see everybody doing polypectomy in different centers of the world. They've got their videos downloaded. You see that, follow that, go for the simple ones. Don't try and be an expert when you're not. Stepwise, go to courses, find seniors who are doing, stand with them, learn, and that's how you progress. In our system, because we don't have a structured training program, we don't have uniform standards, we will always have issues until we reach that stage. And so until that happens, it's about individual interest and passion and conscience. At the end of the day, if you don't have a conscience, you don't give a damn whether the patient bleeds or perforates or dies. Because nobody is going to question you, especially in the public sector. So now we've got 6 colonoscopies left. Sajda, I was thinking before lunch, can we do 2?
Yeah.
Okay, so that would, yeah. Paul and Vakar, we can take, we can identify the 2 who are going to have the call. Like before, we've got about 35 minutes or so, hopefully, if they can finish, but even if they don't, it's okay. Vakar, we are not, Paul and Vakar, we are not in a rush, because we can always have a quick lunch, so we are okay for time.
That's okay, yeah.
Okay, so you've got 2 cases now. Then we have lunch break, and after lunch then we will have 4 more to do, which means we will have about an hour of colonoscopy after lunch. An hour, maybe an hour and a half. So if we hopefully break off for lunch, we at 1:30 and we reassemble. We reassemble at 2. We'll have a short lunch today, 2, we go back to the endoscopy. We have 4 cases to do. That is about an hour. So we ideally would like to finish by 3, quarter past 3. Micro teaching on a couple of things which we are yaad dilana. One is reporting, the system that we have, accessories, and cleaning. Most importantly, cleaning. So we'll have cleaning, then time permits, we'll go to reporting, and then to accessories. There's not many accessories that we need to see in colonoscopy. It's different type of snares. If you're going to do polypectomy, you should have snares, and you should have different sizes of snares. If you want to take a big polyp out and you have a small snare, don't bother. Try not to take a polyp piecemeal, especially if it's pedunculated. The piecemeal polypectomy here was an EMR. That's a totally different technique, and I would not allow anybody to do it. Period. Unless you're totally stable, you know what you're doing, you can lift, you can go down, you can go right, you can go left. Okay? You don't have to do everything. Okay? First focus on colonoscopy, forget about therapy. You've got 90% cecal intubation, think about polypectomy, go for courses, learn, then do polypectomy. If you're less than 90%, I'm sorry, you focus on colonoscopy, don't focus on therapy. Polyp detection is something you can maintain your own logs. Find out how many polyps are you picking up in your colonoscopy. You do 50 colons, you don't pick up a single polyp, there's something wrong. So, even in Pakistan. So, you can all make your own diary for colonoscopy from this day on. Do a colonoscopy, I reached cecum, failed because of difficult loop. Could not negotiate, patient had pain, whatever. Boss came, had no problem, did it. Boss came, patient screamed. Boss managed but pushed, not advanced. There is a problem. Boss needs to come to the course. Okay? And so you maintain your logbook. What time did you take to reach cecum? How many times are you reaching cecum? Okay? How much time are you taking to withdraw? How much pain did the patient have? Screaming, you can make it simple. Screaming, yes or no. Little bit of ooh-ah or something. There are scales that you can follow, or you can make your own scale. It can be simple, mild pain, moderate, severe. You have to stop. So you need to look at your patient's comfort and complications, obviously, time reaching cecum and number of time reaching cecum. Ideal, you can try. Don't be too pushed. It takes time. And withdrawal time. Make sure you know. The best way of doing this is ask your tech. Time me. I'm starting now. I reached cecum, time. I'm withdrawing now, time. Tell me if the patient was uncomfortable. You're focusing. He'll tell you. Okay? Ask the patient afterwards if the procedure was acceptable, or was it like never again in my life, and I'll tell my family not to have this again. Okay, so you can make those things and start from today. And you will see, and it's wonderful to see your progress. Over the next 1 year, 2 years, as the number increases, you will see that you're now, oh wow, I'm not doing bad. We only do that. I'm not so sure they're doing it here. It's a bit difficult. We have more numbers here. But at Patel Hospital, we have the data for everybody who's doing colonoscopy, number of time reaching cecum, ILM, time taken, all that they will show in UK. All parameters are monitored for everything.
So, when as colorectal surgeons, we had a problem with our colonoscope for more than a year. Well maintained, so we were doing more flexible colonoscopy. And then
You have a flexible sigmoidoscope separate?
yes.
So you have one 60 centimeter flexible sigmoidoscope, and you have a colonoscope.
Yes. So the colonoscope was not working. So by the end of last year, we got it managed and it worked. During that time, we have had this colorectal workshops. 2 years ago, we were discussing the cecal intubation rate has to be up to 90%. That's in almost all of the cases, the endoscopist needs to get to the cecal mechanism. What we had in our hospital, I'm just telling about the hospital experience. There is a section called PMRC, Pakistan Medical Research Council. And then they have gastroenterologists there and they're doing colonoscopy. We faced resistance when we mentioned it, that point came up in the workshop, and then we asked them to come and that point was discussed, and it's published everywhere. And when we asked them,
90% is the basic.
yes,
I would be very disappointed if I had 90%. I would have sleepless
but
nights.
this is the basic. This
This
is
is the
least-
minimum.
This is the least that should.
बड़े वो लगा देते हैं bump.
When we put the point across to them, telling this is what we need, they resisted.
Resisted in saying that this is not necessary.
It's not necessary. First they said it's not necessary, and then they said, "Okay, now you have made it mandatory for us to reach the seeker,
Yes.
and it takes longer time, and we have more blood pressure." So at least till 1 year and a half, they kept resisting, and now sometimes they do want that, and they say, "Okay, you have made a big, huge problem for us because we need you.
So-
that's your demand that we go."
It's not your demand. When you say colonoscopy, what does it mean?
It has to be the colon.
It means examining the colon. Cecum is part of the colon.
Yes.
So you're not demanding anything. You're saying if you write colonoscopy, you complete it. And if you don't complete it, call it flexible sigmoidoscopy, period. But don't do this. I have also seen this. When you don't reach, you say, I was going to do flexible sigmoidoscopy. This is very common. Reach to sigmoid. No need to go further, so I did not bother.
तार से चेक करियो.
हाँ जी.
लाइट हम.
हाँ
ऊपर.
लाइट में सॉरी सर.
देखो झूठ बोलते हैं ना यार यहाँ पे.
सर.
ये झूठ जो है पाकिस्तान में नहीं जाएगा.
लाइट में
कौन से पकड़े गए ना. मैंने इसको क्या कहा था. ना अर्स चेक नहीं बचे. Everything means air flow, water लगा, suction, movements, ठीक है, light. Light in nature check, it's not been done. You've not done your pre-flight check. Live am? अच्छा, oh sorry, right, okay. Right, okay, fine. Place it yes, or comfortably on the bed so that it doesn't interfere, right, okay, and now you can grip. You can wipe off any gel off your fingers and grip your scope, okay? Right, okay, fine, and right. Okay, off we go. Okay, center your scope, center it. Use your torque to do that. Yeah, that's good. Excellent, fine, and proceed. Right, so advance, and you can inflate a bit of air. That's good. Opening up nicely. Right, okay, that's good. Good. And keep it centered. Keep it centered. Down, tip down, tip down, tip down, tip down. That's good. Slight anti-clockwise torque. Slightly, yeah. Not too much. Yeah, okay. Tip up. Tip up. Anti-clockwise. Anti-clockwise. Yeah, that's fine. Just hold it there. Hold it and tip up. Tip up. Now, let me show you one thing. Just grip your scope up here. Don't try to do anything very clever. Stick to basics and you won't go wrong. Tip up. Tip up, 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 and now clockwise. Gently, gently proceed in. The ball prep is very poor. Okay. Slightly anti-clockwise and keep going. Keep going. That's very good. Excellent. No, sorry. Tip. Because the problem is the ball prep is not good, so obviously you have to be a bit careful. Right, okay? Keep going, proceed, proceed. Now slightly, yeah, clockwise rotation, torque, right? No, not too much. Tip up, up, and just go there, yeah. It's going to be a bit of a problem there. Tip up, 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 up. Right, okay. and slightly anti-clockwise. Yeah, that's excellent. Anti-clockwise, tip up, anti-clockwise. Clear your lens, clear your lens. Don't let go of the talk. Keep it firm. Otherwise, you lose your position and waste your time. Okay, so that's very good. Hold, no, don't lose. You should be holding it firm. Don't let go. Keep going. That's very good. Keep going. That's excellent. No, don't let go. Maintain the pressure. That's excellent. Good. It will hurt your hands, but doesn't matter. Right. Keep going. Don't stop. That's very good. Excellent. You are doing very well. Okay. So, in spite of bad bowel prep, you've been doing very well. Right. Okay. Just hold it there. Now, clockwise. Clockwise. Yeah. Clockwise. Clockwise. Bit of an angulation there. So to make life easier for yourself, you can turn the patient over onto his back. Okay? So बेटा से करें आप जरा उधर आ जाएं इधर सीधा लेटें. Hold your scope while they are turning him around. ठीक है? Good. उधर वो बढ़ी में खा. हाँ. वो ना नंद बियादर वो वेल. बहुत नहीं करता. Important thing is never lie to your supervisor. Okay? Otherwise you don't learn. Right. He lied again to me today. Right. Okay. Fine. That's okay. Good. Right. Right. Okay. Now just hold it. It's a bit of a poor bar prep. So not entirely your fault, but anyway, still. Right. Okay. Just wiggle it about slightly up and down. Rotate a bit. Now withdraw your scope a bit so that we get a clear view. Right? Okay. Now, no, not too much. Not too much. Okay, that's fine. Right. Now you can see the lumen more towards 1 o'clock. So give it a clockwise rotation a bit, slightly clockwise, and turn a bit more clockwise, and turn the tip up. Tip up. Tip up. Tip up. Up. Okay. I think just to be fair to you, I'll help you through this bit, right? I know you could have normally done it if the bowel prep was good, but the bowel prep is bad, so I'll give you a little hand here. Okay. So, यार ज़रा थोड़ा सा वॉश कर लेते हैं अगर खाने को, ठीक है? वो इनको काफ़ी हाँ हाँ करें शाबाश यहाँ पे हाँ और भी दें ज़रा हाँ शाबाश गुड और हाँ और भी दें प्लीज शाबाश सॉरी चेक कर लेते हैं नहीं ये वो है बाउल प्रेप अच्छा दिया ना तो इरिगेशन एक मिनट मैं देखता हूँ अगर रास्ता साफ हो गया हो तो ठीक है मैं निकल जाता हूँ वरना तो इरिगेशन दे देंगे Now I've got you there, okay? Well, I didn't do much anyway. It was just a bit of washing and maneuvering around. I'll give it back to you. Right, okay? ठीक? Bravo. Look on the anti-clockwise talk all over. Give a bit of anti-clockwise talk. and tip up. Okay. Withdraw your scope a little bit, and now just hold it there. Don't withdraw anymore because otherwise you lose your position. Tip up, up, and just a bit of a torque. You can see it there, right? Even this, so tip up, up, up. यार थोड़ा सा वो वॉश दे, हाँ वॉश कर दें क्योंकि वो फिर उनको नज़र नहीं आ रहा सही. हाँ ठीक है, शाबाश, दैट्स गुड. ठीक है, दैट्स गुड वे ऑफ गेटिंग योरसेल्फ आउट ऑफ द सिचुएशन. ठीक है, दैट्स एक्सीलेंट. हाँ हाँ ठीक. हाँ, we're follow that, look at the fold there, and that will suck that bit of fluid off. Yes, yeah, there, yeah. Right, now follow that fold, roll it up, push your scope in a bit, and follow that fold around. Okay. ठीक है. ये ज़रा यार वॉश दे देते हैं मेरे ख्याल में थोड़ा सा. हाँ हाँ, you can progress, yeah, it's going, yeah, move on, yeah, don't push it in, yeah. एक मिनट इसको, हाँ एक मिनट इसको थोड़ा सा इसके लिए मैं let me do it for you. ठीक है, otherwise बिल्कुल, आई एग्री. बड़ा बांधा था मिलाओ शक्ल बच्चे. बांधे पका रही तो बांधे. चलो पाकिस्तान और सीधा पारा बांधा पका. Just need a bloody excuse. थोड़ी सी तकलीफ होगी, ज़रा सा बर्दाश्त करें, अभी ठीक हो जाएगा. ठीक है. Basically, I'm taking out a loop for you as well. उस देखा, I'll give you the scope. You want me to build the nose, ठीक है? And now it's a bit of a up लगा, ठीक है? ठीक है? Now ये मैं खाने निकाल लेते हैं फिलहाल. हाँ ये निकाल लें. ठीक है. एडवांस, अभी एडवांस करो. अभी देख थोड़ा सा बेटा होगा, आपको तकलीफ होगी. हाँ इस वक्त, हाँ शाबाश. ठीक है, एडवांस. हाँ थोड़ी सी हो रही है, ज़रा सा उससे जा रहा है यहाँ पे, ठीक है, लोगों ने एंटी क्लॉकवाइज, वो अभी एंटी क्लॉकवाइज, या वो एंटी क्लॉकवाइज, या ओके, उससे now go in a bit, a bit more, okay, just wait, ठीक है. Now here, give it a clockwise torque, quite a lot of it, and try to withdraw. Yeah, anti-clockwise work, anti-clockwise, give an anti-clockwise torque, and try to withdraw. Now tip up, keep your lumen in, because if you can't see the lumen, don't do any type of anything clever, because then everything is blind, ठीक है? Because you want to see the effect of your, right, okay, bring the lumen into view.
Torch feeding will go on. Torch feeding will go on.
Sir?
A torch is also a feeding will go on.
Seshe.
Because which torch will take another baby drop taken.
ना दागा ना माख के तो lumen ऊपर रखा ना, तो lumen को दागा view पे रखा ना. You can't. Suction रखा. Lumen रखा. Let's see. I'm trying to loop resolution for my noses. No, then it's difficult to tell. ना पता नहीं लगी. Both hands getting it. ठीक, ओके. थोड़ा सा ज़रा, या चलो ठीक है, ऐसे ही ठीक है. हाँ, नहीं इसको रहने दो फिर, ये और उसे ठीक है. हाँ, उस चीज़ का ना. नाउ यू कैरी ऑन. Clockwise torque work, and lots of it, lot of clockwise torque, more. No, you are losing your lumen again. Yeah, and go anti-clockwise if you can't get the lumen. Yeah, that's good. That's what you want. Keep going. That's good. Good. Right. Okay. Keep going. You need more torque there. More torque. Keep going. Yes. Withdraw a bit and keep going. No, you are losing ground here. Withdraw a bit. Yeah. No. Yeah. You've lost it. Dark. Abbiamo passato una volta da un certo maschio. Huh? No, you should guide. You lost it again. Let's do another thing, okay? आप ऐसे करें जी मेरी तरफ मोड़ लें अपने आप को नहीं इस तरफ नहीं ऐसे इस तरफ अच्छा मुँह इस तरफ कर रहे हैं ये पाँव जरा उठा लें हाँ ठीक है दूसरा भी उठा लें शाबाश बहुत अच्छा ठीक है
थोड़ा आगे कर देता हूँ
फर्स्ट क्लास ठीक है तो we moved him into right lateral position right well let's see if that would open up things for you yeah okay so right so when we move most of the angulation which was there should open up for you right okay so let's see if we can negotiate that better right okay right okay so I'm going to do a bit of loop resolution right okay right okay so I'm trying to resolve the loop I'm withdrawing the scope but it's advancing right and I'm sucking out any air right okay right okay so, right okay so I'm just giving more torque there and making progress right okay so more torque and advance now advance is going to have a bit of a it's running away no it's looping again so we'll just gain some ground here okay and try to then engage this one okay so I'm just going to थोड़ी सी तकलीफ होगी भाई यहाँ पे need a bit of a lubricant because it's dried up a little bit
So it's very easy to think we're in the cecum. Okay? It's nothing nasty against you or anything. But always, 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 a patent flexure looks exactly like the cecal pole should do. Appendix, see it? Draw back the scope, big wheel back, and turn in. Okay? Now with this guy, we don't have to get in, but it does help a little bit with conformation. There. There you go. Okay. What's that? There you go, my friend. Now you can take the tube back. So, you did absolutely brilliantly. You got all the way to the hepatic flexure. Yeah? What I recognised was that the torque itself, you need to apply it, but what you're tending to do is go, then let go of the scope. Go and still let go of the scope. Come round and apply the torque. Yeah? Come round and apply the torque. Draw back, and then that enables the scope to steer around the corner. So you're well up the terminal ilium. Go back in. Go back in. There it is. Steer it in above. That's it. Steer it in. Go on. Go back in. Don't blow. If you blow now, it will cause a problem. Now try it. That's it. Now try it. Water. There. Well done. Don't suck. Do not suck. Excellent. So where are you now? And stop sucking. How do you feel? So you got into there,
Yes.
you got to the hepatic flexure. So how does that make you feel? Are you happy?
Yes.
Okay, my friend. Just take the tube out now, my friend, nice and steady. Nice and steady. Well done. So we've not seen anything untoward there. So start taking the tube out, my friend. Suck down just a little bit. Just pause a little fraction. Go forward. Just go forward. And it's a little bit of food debris. That's all it is. Excellent. That's fine. It's just food. Well done. And keep coming back nice and steady. Suck. Brilliant. And keep coming back, boss. Keep coming back. How are we doing, Eric? Terminal ileum.
Oh, very good. Very good.
Does he look happy? Is he happy?
Yeah, happy.
Does he say he's happy?
Yeah.
Or is he just saying he's happy? He thinks he's, is he saying he's happy or is he just saying he's happy?
I'm happy.
You're not happy?
I am happy.
He's not happy.
He's happy.
He's happy. Excellent. Keep coming, my friend. Keep coming.
Pretty clean. This is pretty clean.
She's asking, is this hepatic flexure?
No, that's splenic, if you're looking at the scope guide. You've already gone past the hepatic. You went past it and then went back into it. So this, what you actually did on the withdrawal, you come back and then you... Remember when I said to you, go back there and have a look? You were at the hepatic and then it made you go back. That's when you were at the hepatic, my friend, to go back down to the cecum.
Because he surpassed the triangular transverse and he came back.
Yeah. Excellent. Slow down. Well done. Nice and slow. Nice and slow. Terminal ileum. No, not now.
That's what your target is.
He's done it.
इतनी दूर ले गया है कि मैं यही बोल रहा था
Relax. It's big wheel forward, then big wheel back. Slow this movement down. You don't need so much wild movements. Okay? What I'm trying to get you to do, sorry, is to see this. Bring it round. See it? Bring it round. And now that's it, and let it go back. Your torque keeps the lumen in view. That's better. Well done. Yeah? Yes. Now what I would do, because we're getting close to being in the sigmoid, I'd get him back on his left. Reason being, you're in a straight descending colon just before you come into the sigmoid. Gets everything back into the left, and you always never retrovert with the patient on the back. Only retrovert That's air. That's air, my friend. Okay, take some air out. Is that better? Anti-clockwise, boss. That's it. Great stuff. Clockwise. Big wheel forward. Excellent. Hands down here. There. The scope will bring it back into view itself. Turn in. Big wheel back. Go on. There. Yeah?
Yeah.
That's great stuff. That's brilliant. That is what, see, steer into it. Excellent. Keep coming back. 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 Well done. Keep coming back. Keep coming back. Relax the scope on the bed. Relax the scope on the bed. That's brilliant. Keep coming back. Keep coming back. Keep coming back. Well done. Keep coming back. Get straight. Keep coming back. Now, my friend, what are you going to do? How are you going to do it?
Big wheel down
Yeah?
and then small wheel down.
Okay. And just going to make this look back on itself. Might be a little bit uncomfortable, my friend. Advance, you advance. Not me. Clockwise torque. Go on. Got to put the torque on. Commit to the torque. Don't suck. You cannot see if you suck. Don't press it in. Just touch. Just touch. Good man. Don't suck. There you go. Now, just put the scope there. Blow. No, don't. So what we're doing, we get it there. He needs to just go that way, just a fraction. Well done. Right. Now look. There, so it's there in the distance. Rotate, rotate. Go on, rotate. Yeah. That's not far. I knew that wasn't far enough back, that wheel. There. Okay? Now, just let go of the wheels. Let them go. Just let them go. Let them reduce naturally. And now slowly take the tube out. Just slowly take, let go of the wheels. Let it come out naturally. There you go, done. Ooh.
Withdraw. Withdraw. Hold it there. Hold, 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 hold. Don't do anything clever. Just see where the lumen is. अच्छा ठीक right so just
Are we live?
Right, okay, that's the ileocecal valve and the cecum. But there's not a lot you can do. Because the bowel prep is bad. He has a history of constipation, that's why his response to bowel prep has not been very good. Now start your withdrawal. Okay, that's good. Well, the bowel prep is a problem here because I never see, well, very rarely I would see a bowel like this.
So should I try to go into the area? Or
No. तैयार सिगमोंड ना होते हैं चलो इलियम कोशिश कर रहा था मक्के लागत आजाम का सवा वापस रहा था obviously this is going to be difficult in this part. So try to exercise as much as you can. Okay, that's good. Right. That's good. Yeah. Okay. If a fold comes in front of your field, point away from it. Yeah, that's fine. Go back. Come out. Now that's coming from that side, point away from it. Yeah, okay. क्या यार ये कभी आप कहते हैं और लाइव या कभी नहीं कहते मैं करते रहे तो फिर आप लाइव हटा देते हैं क्या अच्छा right okay so just when you are coming across okay clear your lens right okay withdraw now just see now look up look point up look above that fold look just rotate it a bit so that you make sure that you are looking into every crevice right so in a circular manner now look down okay look across there that's good now okay that's fine now centralize it and start withdrawing again normally you are expected to suck out the air but if it's impeding your examination don't do too much of it right you can do it at the end because the important part is not to miss any lesions. I mean patient comfort is important as well but if he's not terrible ठीक है भाई हाँ ठीक है so keep on asking but there's no harm in talking to the patient because I've been doing all the talking for you but you should do it yourself okay now look up there because you are missing yeah okay so keep yeah okay withdraw a bit yeah angle it up and rotate it a bit yeah that's fine so a bit of talk there and again talk on the other side yeah okay so clear your lens it's important to have a good vision now withdraw gently that fold is coming across so look away from it now okay just hold it there don't have to right okay just go back in a bit and look at the 3 o'clock position between the fold okay so yeah and now rotate it towards the 3 o'clock that's good and look up now that's excellent very good now fine okay right okay now fine as the bowel prep is poor so try to avoid major feces because they are difficult to get rid of so try to keep it centered but okay wash your lens now wash your lens that's good withdraw that's very good that's good control withdrawal right okay tip down now that's good up yeah look that's fine good look away yeah okay fine okay that's good right okay now keep coming out right okay that's good okay right fine that's okay try not to suck too much air because it will collapse जी أو ما هكذا جات ما هكذا previously look this is obviously not an ideal bowel prep for you ठीक है keep coming out a bit so slowly ठीक है सही है हाँ normally splenic fracture hepatic fracture you'll get a sudden Daga. I always go back and forth because there's so many feces there. Okay, so okay, that's good. Clear your lens again. Okay, that's a good exercise. Okay, right. Avoid the feces because it will again make it difficult for you. Mother, we didn't say anything. Okay, there's a lot of it. You can't aspirate all of that. Right. Okay. If you are unsure and if you got a bowel prep like this, you can always ask for a repeat colonoscopy with better bowel prep. Okay? Or you can alternatively ask for a CT colonography. Because I'm not 100% sure that I've excluded all types of small polyps. So if you are, in this case, you are bound to miss polyps of 5 to 10 millimeters in size, even bigger polyps. So if the patient clinical history is suggestive that there might be something there, you must do another examination with better bowel prep, or alternatively, if you got good CT colonography facilities, then ask for that. Because with this one, with hand on your heart, you can't say that it is entirely normal, right? Okay, because there's a possibility that other lesions could have been missed, right? Down, down, look down. Yeah, that's fine. Okay. Because you never know how many polyps are hiding in that feces. Right, okay. Oh. Right, okay. Now, don't lose your central view. But once you lose your central view, it takes a lot of effort then to get it back.
Should I just make it a little bit?
Oh, you can. Oh, take those. Now it's better. Right? Move away from it, yeah. Take the right. Good, good. Normally, whenever you report your colonoscopy, you always write about the bowel prep. In this case, it is poor, right?
Behind this one?
Yeah, okay, yeah, good. Oh. Right, think that that's okay. Good, look up, up. That's good. Right, okay. Now, swing around to the other side. Swing it round. That is good, right, okay. Now, come out slowly. And now look behind that one there. Come out a bit and look over it. Okay, that's good. That's fine. Good, that's good control. This is what we want you to do. Move it across there. That's good, right? And yeah, move it across. Yeah, that's good. Now keep withdrawing. Withdraw. Keep withdrawing. Okay. Right. Look up. That's okay. Good. Look up, side, yeah. Clear your lens, yeah. Clear your lens, lens, take it, yeah, easy, that's good, right, okay. Now these are the sigmoid rectal folds, they are also important, right, okay, because you get to see. Yeah, so you just have to negotiate around them. Look up, it's up there, right? Okay, now, yeah, okay. So always maintain your luminal view, right? That's good. Clear your lens. Again, there's not a lot you can do here because it's feces. Clear your lens, okay? Yeah, okay, yeah, come. Clear your, yeah, okay, keep coming out. Yeah. Right, okay. The other thing is sometimes the bowel prep is so bad when you start it, don't do the procedure. Just stop and ask him to come on another day. Just right, okay. Check. Yeah, come out a bit. Just check that fold. No, come out a bit. Out a bit. The fold on the left, on this side, on 9 o'clock. Yeah, that's fine. Okay, that's all right. Good. Fine. Just wanted to see if there was any polypoid tissue. Okay, out. Out. Yeah. See, these folds are important. You have to make sure that you check them. Okay. I don't know whether you'll be able to do it with so many feces in. Come out a bit. Yeah. Just a minute. Let's see why this place is bleeding. Come out a bit. Let me check it out. Wash there. You got a hemorrhoid. Okay? Right. Okay. If you want to do retroversion, put him on his side, it's easier that way. It's okay, you can come out. You come up to the...
So human should be on the 12 o'clock and then we go side and at the same time
up.
Yeah, up.
And push it.
Yeah.
And then rotate a bit,
Yeah.
and then you see it. Right? You come right to the anal verge, and then...